Thank you. Thank you so much, Manuel. It's a great pleasure to be here today. Thanks for inviting and to everyone who joined. So I'm Débora, I'm a third-year PhD student at the University of Surrey, and I'm going to present some of my PhD work on indoor light supplementation for older adults in real-world settings. So just a brief introduction to remind us that advancing age is associated with a number of changes in the circadian system and in the eyes, such as a yellowing and clouding of the lens, reduction in pupil size and in the number of photoreceptors, which leads to a reduced light input to the SCN, providing a weaker drive for our 24-hour biology. And as a consequence, there's a reduction in the amplitude of hormone secretion and in rest activity rhythms, along with other changes in sleep and circadian rhythms. Also, older adults often experience insufficient light levels during the day due to impairments in mobility or insufficient indoor light exposure. However, many studies have shown that bright light therapy may help alleviate some of these problems by increasing daytime activity, improving sleep quality and sleepiness, increasing stability of rest activity rhythms. But most of the studies have conducted bright light therapy in institutions or nursing homes, which are controlled environments that can limit the scope for light interventions. And also most of them have conducted these interventions with patients with Alzheimer's disease or other cognitive impairments. So there's a lack of light research on healthy older adults in real-world settings. And also there's a great variability in applied light therapy in several key parameters like duration of intervention. This can range from 20 minutes to 17 hours. Timing is also highly inconsistent, and interventions are conducted across various seasons. So there's a substantial diversity in methodologies in light studies, which also highlights the need for a better understanding of light intervention effects in this population. So just a bit more of background literature. We've conducted this home-based study in older adults with sleep problems to compare the effects of a blue-enriched light and a control white light for 3 weeks in a randomized crossover design. So these data were collected by CAT a few years ago. And this was self-administered light, but they were asked to use it for 2 hours in the morning and 2 hours in the evening, and registered these light exposure times in a light timetable. And we found that chronotype significantly predicts timing of light supplementation. As we can see here, early types starting the intervention earlier. Timing of intervention was also very important, with more blue light in the morning being associated with increased stability and decreased sleep fragmentation, whereas evening light exposure increased sleep latency and lowered sleep efficiency. And finally, those who spend more time outdoors had increased amplitude, daytime activity, and advanced bedtime. So these findings indicate that the positive effects that we see in lab-controlled studies can be translated to real-world conditions, but there's still a gap in our understanding of the complex behaviors influencing light use in daily life, which is one of the aims of the Enlighten Me study. So this is a major international study with 20 partners across Europe, and it brings together researchers, industry, policymakers and the public with the overall aim of understanding the impact of light in older adults' health and well-being, and developing better lighting solutions and policies. Here in Surrey, we lead Work Package 3 that aims to understand the effects of an indoor light supplementation on sleep, daily rhythms, well-being of older adults. So the study spans multiple cities. Older adults were recruited in Bologna, Amsterdam, and Tartu, with a broad recruitment strategy across multiple seasons and in real-world settings. And the study design incorporates multiple waves of data collection. So we had 5 groups of people joining the study, and we also made sure to not include, to time these waves, to not include any seasonal transitions within the data recording periods so that we had more stable measurements across the protocol. All participants completed a 2-week baseline assessment and a 2-week follow-up. And during both phases, we objectively measured rest activity rhythms, light exposure, melatonin onset. The intervention group, after the 2 weeks of baseline, they received the halo lamp to use it daily for 12 weeks, whereas the control group maintained their usual lighting conditions. And during this 12-week of light intervention, participants were asked to place the halo lamp in their primary living area and use it on bright mode during the day and turn it off 4 hours before bedtime. So here we have some characteristics of the light spectrum, and some metrics. So it delivers around 8,000 millanopic EDI. The mean age and the age range was very similar in all cities. In all cities, we also had more females than males. And we wanted to recruit healthy older adults in terms of cognitive impairments, so no participants with neurodegenerative disorders. But still, other disorders were prevalent. So we had a high proportion of people with overweight, and I've also highlighted the most prevalent disease. And considering all the variability that we see in real-world conditions, we managed to preserve some validity, as we can see with DILMO data, with morning types having an earlier melatonin onset comparing to evening types, which is also illustrated in these 24-hour activity and light profiles. So although this is expected, we were very pleased to see this because we have a very complex data set, but still this aligns with what we know and validates our population. From the baseline data, we also looked at patterns of light exposure by categorizing individuals in low, moderate, and high light exposure. And then we use these 3 categories to see how they are associated with actigraphy parameters. So people in the high light exposure group exhibited significantly higher daytime levels of activity. The low light exposure group had higher activity fragmentation, so less consolidated periods of wakefulness, and an earlier onset of light exposure. And because we had a sample of older adults, some of them with mobility issues, we wanted to investigate light exposure patterns between those with and without mobility problems. And as expected, those with mobility conditions get much less light exposure during the day and also spend less time outdoors. which may have important health implications for this population. And regarding the effects of the light supplementation, first we looked at those who reported using the halo lamp to try to investigate what were the main determinants of light supplementation use. So out of the 98 participants in the intervention group, about 50% reported using the halo lamp. So the next slides will be only with people who reported using the halo lamp. Chronotype was one of the key determinants of timing of light supplementation. So similar to the previous study, morning types started this light supplementation earlier with their usage peaking in the morning hours. And they also ended light supplementation earlier compared to evening types who showed delay in both the start and the end time of light supplementation. Light supplementation also depends on the overall light exposure and time spent outdoors. So these are the same light categories that I showed before, just to show that those in the low light exposure group spend much less time outdoors, but they also have the highest light supplementation use. So maybe there's a compensatory behavior. Those who get less natural light exposure also reported more time using the light supplementation. And when we stratified our data based on the timing of light supplementation, we also see some benefits in some measures. So here we created a cutoff point based on the median start of light supplementation. So those who start light supplementation before this cutoff point had higher daytime levels of activity and lower intraday variability, so lower fragmentation compared to those who start later in the day. And similarly, we created a cutoff based on the median end of light exposure. So those who end the light exposure after 6 p.m. had higher intraday variability compared to those who end the light supplementation earlier. So what these findings means for light supplementation is that counteracting low light exposure may be a good opportunity in light supplementation to benefit those who get poor light levels due to specific health conditions or mobility problems. Optimizing light timing to minimize evening light exposure and prioritize morning light exposure also seems to be more beneficial for this population. And circadian preference also strongly influences how people are exposed to this light therapy. So tailoring light strategies to individuals' chronotype also seems to be important for effectiveness. And I've also listed some research gaps to help us find opportunities for future studies, and these include the need for more refined investigation in real-world settings, investigating other determinants of light supplementation like socioeconomic level and education, and also expand this population to older adults with eye conditions, as our study was limited to healthy older adults. We also need more integrated analysis, like cluster approaches to integrate all relevant variables, and a genetics perspective to investigate how clock gene variability influences in light exposure responses. And with this, I thank my supervisors, the chronobiology section, our funding sources, and EU collaborators. And thanks everyone for listening.